The hardest part about reacting to the Pitt is trying my best not to cry on camera. In episode 4, I wasn't ready for this. Let's break it down.
I need rooms cleared and cleaned, so I'm shuffling the deck.
Yeah, but why are you moving him into peds? I'm just about to extubate him.
When you extubate a patient, that means to remove the breathing tube. When you intubate, you put in the breathing tube.
There's no kids in there at the moment. The family can have some privacy. There's nice pictures on the wall.
So what's going on here is that they're discussing a patient who's an old man who originally came in because they had a really bad case of pneumonia that developed into sepsis. Now this patient, he has a DNR order as well as a request not to be placed on any sort of artificial life support. But before any of this was known, in addition to giving the patient antibiotics, which is the standard of care for pneumonia, they also put a breathing tube in him to maintain an airway, to which they then attached him to a ventilator. Now a ventilator is actually considered artificial life support because it's a machine that does something that the body should be doing by itself, which is breathing. And how a ventilator is able to do this is that it has two phases. It has an exhale and inhale phase. For the inhale phase, what it does is it forcefully pushes a mixture of oxygen and air into the lungs, and that oxygen can then bind to the blood. From there, the ventilator takes a brief pause for the exhale phase, in which the lungs naturally recoil and it pushes the CO2 out of the body. But given that this patient's condition was getting worse, and it also became known that he didn't want any sort of artificial life support, keeping him on a ventilator would go against these wishes, so that's why they're removing the breathing tube to honor this patient's request. Ultimately, instead of prolonging suffering, this patient requested that we let his illness take its natural course.
How long will he live without the oxygen?
This is always the number one question families want answered first.
It's difficult to say. Once the tube comes out, it could be anywhere from 30 minutes to several hours.
Once you take a patient off the ventilator and then you remove the breathing tube, the patient has to start breathing on their own again. And for a situation like this, the patient's lungs are way too weak to be able to sustain life. Now, as far as how long it's going to take the patient to pass, like Dr. Robbie says, there's no exact timeline. It can take anywhere from minutes to hours, even sometimes longer, but it all depends on how weak the patient's lungs are. When the ventilator is first removed, the patient can take a few breaths on their own, but eventually, since their lungs are so sick and weak, their breathing is going to gradually get slower and slower. From there, what ends up happening is that the oxygen levels will begin to drop and the CO2 level, that CO2 waste level, will begin to rise, and this is because there's minimum amount of inhaling and exhaling taking place. What ultimately is going to lead to this patient to die is that the accumulation of CO2 in the blood. Now our body is constantly making CO2 as a waste product, and the way we get rid of it is that we exhale and we breathe it out. But the slower someone breathes, the less CO2 gets removed. So instead the CO2 accumulates in the blood, and it gets to a point where so much CO2 is in the blood becomes acidic, and this is what leads to the patient's death.
When I extubate, we're going to suction the back of his throat. We're going to give him some glycopyrrolate drops, which will cut down on his secretions.
We also give glycopyrrolate to kids who excessively drool.
We'll get morphine for any pain, and we'll give him some oxygen in his nose as a comfort measure.
When taking a patient off life support, the primary goal shifts from keeping the patient alive to keeping the patient comfortable. And to achieve this goal, like Dr. Robbie said, we're going to use a combination of glycopyrrolate, oxygen, and morphine. So let's go through all of them. Now, glycopyrrolate, that's a medication that we can give either in a liquid form or a pill form, and what it does is it dries up mucus and saliva. It works by blocking the signals that the brain sends to the different glands of the body to produce the mucus and saliva. And this is really important because usually in a patient of this condition or on their deathbed, it's very difficult for them to swallow. So if you have this production of all the saliva and mucus, it'll just build up and it won't go anywhere, and the patient will have a choking sensation. And since the patient really can't swallow, Dr. Robbie, he's going to give a liquid form of glycopyrrolate underneath the patient's tongue, because underneath the tongue there's a lot of blood vessels, and when you place that medication on top of these blood vessels, it gets absorbed directly into the blood a lot faster than if you were to swallow it. Next, we give the patient morphine, which is an opioid that acts directly on the brain. Now, opioids, they reduce pain, of course, but just as importantly, they calm the brain's response to low oxygen, because normally when a patient's oxygen levels drop, they start to gasp and they start to panic, and this is because the brain is sending signals to the body saying, hey, we're suffocating here. Morphine turns down this signal, so instead of feeling like they're suffering, the patient's really unaware of what's happening and they feel calm and relaxed. And on top of it all, we give the patient a little oxygen through a nasal cannula that runs through the nose, and this is just to make every breath they take a little easier. And again, the main goal here is just to make sure the patient is in distress. We want to make sure they're calm, they're comfortable, and they're at peace.
Just to be clear, your father's dying, and you're choosing to allow that to occur naturally.
It's really, really important to remind the family of this,
rather than subject him to a torturous amount of procedures which would only delay the inevitable.
And this is something that families really need to hear, because in that moment when they're witnessing everything taking place, they can feel like they're the ones making the decision to let their loved ones pass, but absolutely not. You have to remind them that the patient had an illness that their body can no longer overcome, and by doing what they're doing, they're honoring the patient's wishes and allowing them to pass peacefully.
There we go.
So once they remove the breathing tube, then they're going to apply a little suction just to get all that mucus out of there.
We'll give you some
And
oxygen
then
in your nose.
the oxygen via the nasal cannula,
Drops under your
the
tongue.
glycopyrrolate, and the morphine is going to be given via the IV line.
How are you doing? I called Nick's dad an asshole. Why would I say that?
Clearly, this is a patient who's very sad and traumatized over a situation.
Why don't you tell me about school? What are you studying? Do you do any sports?
Dr. Mohan's like, what the hell are you asking this poor patient?
I don't know why you're asking me that.
Well, it's important that you focus on the good things in your life right now.
So here we clearly have a patient who's crying, she's emotionally distressed, and she's opening up about how she feels. And instead of meeting her at that moment, Dr. Santos, she kind of shifts the conversation and she starts asking her what's her major. Now, on the surface, this might seem harmless, like she's trying to distract her so she can focus on something else. But here's the problem. When a patient or anybody is feeling this upset, they're not looking for any sort of distraction. They're just looking to feel understood. So when Dr. Santos says focus on the good things in their life, to the patient, it can actually come off a little bit dismissive, like their feelings are not being acknowledged or they're not being taken seriously. As a doctor, when you see a patient so visibly distressed, the first thing you can do and the best approach to a situation like this would be to first acknowledge the patient's emotion. Say something simple like, I can see how upset you are. Because at the very moment, as a doctor, when you're communicating with the patient, all the patient wants is just to feel heard.
His father thinks I killed him, and you're asking me if I play sport?
She's 100% right to be feeling like this.
Jenna, I can tell how upset you are right now. I see how painful this is.
Perfect. This is how you acknowledge a patient's emotions.
We don't even do drugs. How does that happen?
I can't imagine how hard this must be for you.
Now, this is exactly what you want to see from a doctor. Dr. Moshi recognized that the patient felt a little bit dismissed, and then she starts the conversation by acknowledging the patient's emotion. And she accomplishes this by saying, I can tell you're upset right now, and I can see how painful this is for you. That right there is empathy, which is being able to, as a doctor, to put yourself in the shoes of your patient. And just notice how Dr. Mohan, she's not trying to change the subject at all. She's not trying to fix the situation. All she's telling the patient is that I see you and I'm here for you. More importantly, though, is after she acknowledged how the patient's feeling, Dr. Mohan gave the patient time to talk and vent. And this is huge because most of the time, patients don't need answers right away. They just need to be heard. And by following up at the end with saying, I can't imagine how hard this must be for you, and while gently holding her hand, that combination of words and nonverbal support really helps the patient feel validated, understood, and supported.
You've got a dead bug in your ear. Cockroach.
Sometimes, especially while you're sleeping, a small insect or even a cockroach can crawl into the ear canal because it's wide enough. Now, inside the ear canal, it's dark, it's warm, and as you go further down the ear canal, it narrows, so it's an easy place for bugs to get trapped. Now, in this case, the cockroach has already died, which honestly makes it easier to manage. Now, what the doctor did here is he took a syringe with saline and flushed the ear, just like he said. The treatment here is pretty simple. So when the saline goes into the ear canal, it doesn't go any deeper than it needs to because the ear canal has the eardrum and it stops the fluid from going deeper. So the saline will wrap around any objects within the canal, whether that's a bead, whether that's a bug, and it will eventually drain out. And as it drains out, it'll wash anything out from the canal. Believe it or not, the best way to prevent bugs from crawling in your ear while you're sleeping is not to go to bed with earplugs on. It's actually just to keep your sleep environment clean. Don't eat where you sleep. Make sure you wash your sheets, and just doing these cleanliness techniques will keep bugs away. But overall, a bug crawling in your ear and dying in there is a pretty rare thing to happen, so you don't have to worry about this on a daily basis.
Wendell Stone, 52, chief rigger from Pitt Fest. Isolated trauma to the left chest when a speaker tower came down on him. Looks like multiple rib fractures.
If I'm understanding this correctly, this guy works as someone who moves around equipment for a concert, and a very heavy speaker fell and struck him right in the chest. And since nothing really stabbed into the guy and it's just like a strike, this would be classified as a non-penetrating blunt chest trauma. When it comes to blunt force injuries like this one, what determines what kind of test and what kind of treatment this patient will require are two things. First, the patient's blood pressure, and next, how the injury occurred, like what mechanism, whether it was a car crash or something like that. So right here is a beautiful flow chart that explains all this. So as you can see, if a patient with this type of injury comes in and they're hemodynamically unstable, which means their blood pressure is below 90/60, then we do automatically a few things. The first imaging test we do would be an EFAS, which stands for Focused Assessment with Sonogram for Trauma, and this is just a quick ultrasound just to scan for any sort of internal bleeding that might be taking place. The next test we do would be an X-ray of the chest, and this would be looking at the heart, this would be looking at the lungs, and just rule out any sort of broken ribs that might be taking place. And last, we'd also do an EKG just to check the electrical activity of the heart, because sometimes when you take a force like that to the chest, it can throw off the heart's rhythm and it will beat abnormally, and we can detect that. And once we run all those tests, the most important thing we have to do is stabilize the patient, meaning we want to raise their blood pressure back to normal. And if doctors are able to achieve this and normalize the blood pressure, great, then the next test would be a CT scan. But if not, we know that there's some type of internal bleeding taking place within the body, so this patient would go straight to the operating room, and a thoracotomy would be needed, in which we open up the patient's chest and we examine to see what kind of structures are bleeding and patch it up that way. But on the other hand, if a patient comes in after suffering a blow to the chest and their blood pressure is normal, the next thing we want to know is how this injury occurred. Injuries that occur due to car accidents, falling from significant heights, or getting hit by a car as a pedestrian, these are all categorized as high-risk mechanisms of injury. So even though when the patient comes into the hospital, their blood pressure may initially be normal, this category of injury makes it really likely that some sort of internal bleeding is taking place. So these patients would be treated as if they were hemodynamically unstable, like we saw in the last group, even though their blood pressure is normal. But if the way the patient was injured was not a high-risk mechanism of injury, then they would get a physical exam, an X-ray, and an EKG.
Isolated chest trauma with obvious flail chest, no human pneumo on POCUS, good sats and vitals.
Excellent presentation.
Let's break down what they found on the initial exam. First off, they found a flail chest injury due to the force of the object hitting the upper part of the patient's ribcage. What a flail chest is that when you have 3 consecutive ribs all on the same side that all break in 2 separate spots on each rib. And this creates a detached segment from the ribcage, and in medical terms, this segment moves paradoxically with breathing. And what paradoxical breathing is that normally when you breathe in, you're taking all that air, the ribcage expands, and when you breathe out, the ribcage contracts. Paradoxical breathing is the opposite of that. So that segment, when you breathe in, it moves in, and then when you breathe out, it moves out as well. And Dr. Santos, she also mentioned that there's no hemo or pneumothorax, which is just a slang term for no hemothorax and no pneumothorax found on exam, which is great. Now, just as we talked about the heart in episode 3, how it has on the outer layer a little bit of fluid to make sure it beats frictionless, the lungs have something very similar to that. The pleural space is a tiny space between the chest wall and the lungs, and it has a little bit of fluid in there, so when you breathe, your lungs can slide very easily. But in some cases, when someone takes a severe blow to the chest, this can cause damage to the lungs, and either air or blood will leak from the lungs into that pleural space, and problems can happen. And when air or blood gets into the pleural space, the lungs can't fully expand anymore, so then the person begins to have breathing problems. If air leaks into the pleural space, we call that a pneumothorax, but if it's blood that leaks into that space, we call it a hemothorax. Going back to the flowchart I initially showed you, based off our patient's findings, his blood pressure is normal. The mechanism of the injury wasn't high risk, but he did have an abnormal finding, which was that flail chest we talked about. So he's more than likely off for a CT scan of the chest just to get a more detailed image of the injury.
Okay. How big is the pneumothorax? Got it. Thanks.
So he went for the CT exam and they found evidence of a small pneumothorax, and as we just went over, that's a small pocket of air into the pleural space due to the injury.
Getting short of breath here.
Pain?
No, all that's gone.
Good. The block worked.
Now, it's worth noting, when the patient was initially brought in when we first saw him, his pain was treated. They put him on a temporary nerve block, and what this does is it blocks the pain signals being sent from his damaged ribs every time he breathes, so that's why he looks relatively comfortable. But now, as we just heard, the CT confirmed that there is in fact a pneumothorax with just a little pocket of air between the lungs and the chest, which is preventing the lungs from fully being able to expand, and that's why the patient's complaining of shortness of breath.
Sats are down to 85 on 5 liters.
His lung contusions need some help. Start BiPAP. 10/5. That'll open up the bruised parts of your lung.
If you were to look up pneumothorax in any sort of medical textbook, you'll see in bold it says, do not use any sort of pressurized breathing machines on patients. In most cases, when a patient has a small pneumothorax, the best possible treatment is just to keep the patient in the hospital for observation purposes, and over time, the body will naturally be able to absorb that small pocket of air, and the lungs will again be able to expand fully. And during this time, while we wait for the body to absorb the air pocket, naturally, since the patient's having difficulty breathing, their oxygen saturation, or the amount of oxygen bound to their blood, is going to go down because they're breathing less. So if this happens, what you want to do is that you want to give them a nasal cannula of oxygen, which is that piping that goes around the face and into the nose. And that's just a gentle amount of oxygen that supports the breathing that the patient is naturally doing, and it's not forcefully pushing oxygen into the body, into the lungs. But unfortunately, Dr. Santos' decision to place this patient on a BiPAP is going to make this small pneumothorax into an absolute nightmare. Now, BiPAP stands for bilevel positive airway pressure, and it's a machine that's worn as an air mask over the patient's face, and it delivers pressurized air, and this ultimately forces air into the patient's lungs. And since this patient, I think his left lung's injured, when he breathes in, there's already a small leak of air that he breathes in into the pleural space. When you apply that pressurized system, that forces even more air through that leak into that pleural space, making the situation a lot worse. So instead of that small pocket of air in the pleural space slowly going away, when you apply that BiPAP, that pocket of air gets a lot bigger because there's more air leaking through. And with more air in that space, you're also increasing the pressure within the chest, and that pressure is getting forced on the lung. So with each minute that goes by and the patient's on the BiPAP, more and more air will leak from the patient's lung into the chest and get trapped, and all that pressure will eventually be so great that it will cause the lungs to collapse, and also the heart and blood circulation is going to be affected as well. And when this happens, we call this a tension pneumothorax, and it's a life-threatening emergency.
What's going on?
Hypoxic to 78, BP's crashing, systolic's 82.
And just like we thought, the patient got a lot worse.
Absent breath sounds on the left, tracheal deviation to the right.
Okay, the absent breathing sounds and the tracheal deviation, those are both telltale signs of tension pneumothorax.
14 gauge angiocath. Now, tension pneumothorax from the BiPAP's positive pressure. You hear that?
Just as we suspected, because of the BiPAP, the patient's situation got a whole lot worse and they developed tension pneumothorax. Now, to understand what's really happening here, it's important to recognize that our chest is actually divided into 2 separate spaces, one for each lung, and air just doesn't move freely from right to left or left to right. So as more and more air leaks from the injured lung and gets trapped inside the chest, the more pressure buildup there is and the more structures inside the chest are getting compressed. And like we mentioned, the pressure inside the chest can get so great that in whichever lung that the leak's taking place in, it'll eventually collapse, and therefore it's not going to be participating in breathing. breathing. So when the doctors, they use their stethoscope to listen over the lungs, in that side, they're going to hear absent breathing sounds. And what's even scarier is that eventually the pressure inside the chest is going to get so high that it's even going to start compressing on the heart and all the major blood vessels. So therefore, you're going to have less blood circulating throughout the body, and that's why this patient's blood pressure has dropped. Now, to treat this, doctors need to immediately relieve all that pressure in the chest, and they do this by performing a needle decompression. And how doctors do this is that they'll take a thick needle and they'll insert it through the chest wall into the space in which all that air is built up. And as soon as the needle gets inserted into that space, you can hear all the air escaping. It sounds similar to as like a deflating tire, or if you were to take air out of a tire, the same sound. And if you listen here closely, the Pitt does a great job in making sure you can hear this. So take a listen.
You hear that?
But this is only a temporary fix because the patient's lungs are still damaged, meaning every time they breathe in, air is still going to escape the lung into the chest space, so you have to do this process over and over again. So to prevent this, doctors will insert a chest tube right after doing the needle decompression. And what the chest tube does is that since the patient's lungs are still injured, so every time they breathe, air is leaking out from the lungs into the pleural space, the chest tube assures that none of that air gets trapped and it can be removed from the body. And once the chest tube is placed, there won't be that pressure buildup that caused the lungs to collapse, so the lungs can then fully expand again, and with time, that small tear in the lungs will heal, and then once that heals, you can take out the chest tube. So that's all I got for episode 4 of The Pitt. I really hope you enjoyed it, and I can't wait to see you guys next week.